I'm going to just show some vascular complications, and I know these are from my fellows in different cases at Columbia in New York, and different complications. And so obviously it's always difficult to show complications because it's somewhat embarrassing to show things that have gone wrong. But I think it's important from an education and teaching perspective, because we all have the same events, and to learn how to manage them and to get out of the scenarios which you find yourself put into. So the histories aren't that important, but this is a 60-year-old woman, vascular path, prior coronary disease, who had symptoms, and the plan was to do a intervention through the left internal mammary. Preoperative vascular assessment, there were evidence of vascular disease with Doppler pulses distally, but the palpable 2+ femoral pulses bilaterally. When the operator went to get access on the right side, now again, I think I'm sure, how many people here, the majority of the cases are radial, or how many operators? Majority femoral? Again, it seems to be about 50-50. It's sort of, I'm trying to switch to more radial, but I'll be honest, I'm probably right now only about 20% radial. In our lab, we're predominantly femoral still, although there is an emphasis and shift because of complications, patient comfort. And now in the U.S., the Medicare has determined that a PCI is an outpatient procedure, so they will not pay for the insurance will not pay for an overnight hospitalization anymore. So if you keep the patient overnight, it's at your own cost in the hospitalization. So there's also incentive for early discharge and safe discharge to move towards radial. But that being said, I'm talking about femoral complications for the most part. But difficulty getting access. They got flow through the needle, but they couldn't get the wire up. And you can see here, I don't know if this is projecting reasonably well up on the screen, but you can see they're injecting through the needle, which can be dangerous. There's flow, but you see clearly there's a dissection plane here. So the question is, what do you do next? Obviously you're in a dissection plane. You're in the dissection plane with the wire already. You're not going to do anything more from that side. You remove the needle and hold pressure. And the question is whether you abort the procedure. I mean, if it's an elective procedure, you have to decide risk-benefit whether you go forward or not. If you do, you're going to go through the contralateral access. And if you go contralateral access, can you get up on the other side? Should you image what happened here before you start the PCI? And it's probably reasonable to do, because during the PCI, you're going to be giving anticoagulation. If there's some complication where you may not want to give anticoagulation, you'll want to know that in advance. So in this scenario, they got left groin access, looked reasonable, and a aortogram here is done with a pigtail and the descending abdominal aorta. And you see here good flow. So there's good flow distally, and it's fairly common. These dissections that are created retrograde are going to heal. Leave it alone, PCI went forward, and there was no issue. So it's pretty straightforward, not a major complication, but it's nevertheless still one. And if you proceed with the wire and try and go further, you can create more harm. Next case, 65-year-old gentleman. And also this should be interactive. If any thoughts, people would do things differently in any of these cases, please speak up from either the audience or the panel. But this patient was planned for a left plus minus, chest pain, anterior wall ischemia. Get access in the right groin. What you see here, you see a tight lesion, you see some flow into the profunda, but the SFA, there's very minimal flow. So it's either a dissection that was lifted up or something else. And the question is, what's going on? This is an injection through a pigtail in the aorta, and you see here there's a dissection at the distal edge of the sheath that extends down. We go, there's disease up there, but this is the tight area. There is a dissection there, and there's an area of plaque there. And you see a little bit better injection here, and sort of diffuse plaque, and a lot of calcium. Whether there's a real dissection or a tight lesion or not, it's not clear. But the access was obtained right here in the middle of a lot of disease. So the sheath was somewhat occlusive in terms of blood flow getting to the SFA. So there was no real complication except the patient had peripheral vascular disease, and we entered at a very poor point. And this may be an argument, and I don't know if it's being utilized here, is ultrasound prior to access. There's these ultrasound needles, and sometimes, I don't do it, but there's some operators that always, they ultrasound prior to getting access in the femoral. And with the ultrasound, you can see where the bifurcation is, you can see areas of plaque. But obviously that adds another layer of complexity to the procedure and cost in terms of having a machine available. But that, if you had that, you wouldn't have stuck in this region as I did. So there wasn't a real complication here, but it's just entering in a vascular path. When you look at most studies, the complications from femoral access in most series are reported anywhere from 2 to 10%. Most of them are minor. Most of them are hematomas. Are the most common, but obviously there's other things such as pseudoaneurysms, AV fistulas, which for the most part you're going to just leave. I mean, they're typically not large enough to cause any high flow state or any problems. Vessel injury, vessel laceration, dissection. The ones that really are life-threatening are retroperitoneal hematomas, which are, the incidence is anywhere from 0.2 to 0.9%. And then there's the other ones that you see listed there with infection, venous clot, nerve injury with the access. And the interesting thing is when you look at with reports and series from different decades, the complication rates are the same. Devices may have changed and things like that, but the complication rates are in most series, whether you look at from the 80s, 90s, or more recent, are similar. And a lot of the complications are related to how you get access. This is obviously sorry, this pointer is, okay. You really want to be in a compressible area, so you want to enter the vessel at the femoral head. And you want to enter below the inguinal ligament, because if you enter above, your risk of a retroperitoneal hemorrhage is significantly higher. But you want to enter above the bifurcation of the profunda and the SFA. The issue is, unless you have a prior angiogram, you don't know where this bifurcation is. And in general, I target sort of the mid-femoral head, as most people do when you're doing femoral access. And the technique is variable. I mean, I think if you put your thumb on the hip and your middle finger on the symphysis, where your index finger lands is sort of generally where you want to enter. And you sort of, by feeling the hip, the iliac crest and the pubic symphysis, you can mark the tract of where the inguinal ligament is and make sure you enter below it. Most patients it's not a problem. The issue, and I don't know, it's probably more of an issue for us in the U.S. Than here, but we have a lot of very obese patients. And that's really where a lot of the complication rates increase in terms of where you enter, and you tend to not be able to enter as specifically as you do here. The other issue about techniques, some people have moved to using, like I talked about, the ultrasound guided entry. Others have used micropuncture needles, so it's an 18 gauge needle. So if you can do a micropuncture needle, do a small injection. If you don't like it, pull out and don't put the sheath in at that point. And it's just an 18 gauge hole, and you can just hold for a couple minutes and that will seal. And that's just ways to optimize your access. And the predictors of complication, obviously there's numerous. Higher rates in females, diabetics, either small or high BSAs, sheath size, the anticoagulation regimen, renal failure. All these are markers of increased risk of complications. So that's, I want to just now, I know I don't want to go too much over my time, but I have about 3 other cases here sort of illustrating different complications in their management. It's an 87-year-old woman, again, had good radial pulses, 1+ bilateral femoral pulses. And this is what happened, I'm not sure why it's not playing. Couldn't get the wire up. And he had some difficulty higher up, but this is the first picture. So what, and this is, I'm sorry, this is the different case. The access was fine, the sheath went up, the case was done. And it was a PCI of the LAD on Angiomax. They were shooting the iliac angio to do vascular closure, and this is the picture when they shoot the iliac angio. And so what do you do here? And clearly there's a dissection where it was entered, but the wire entered a dissection plane, then re-entered the true lumen. And that's why they were able to get up, do the case. But now, and so what was elected to do is pull the sheath, and assuming that, like I said, showed that earlier case, it's a retrograde dissection that will heal on its own. There was non-occlusive pressure was held for an extended period of time. Hemostasis was good. There were distal pulses. and so nothing was done. However, the patient the next day complained of right lower extremity pain. The pulses in the right groin were Dopplerable all the way down to the DP and PT. They did an ultrasound of the groin. There was no evidence of hematoma, pseudoaneurysm, or fistula, but there was decreased velocity in the right external iliac. But the patient was able to ambulate with some pain, but the decision was not to do anything. Follow up a week later, patient said she's continued to have pain in her thigh when she ambulates. She can walk about 2 blocks and then starts getting pain. So they decided to bring her back to the cath lab to take a look. So this is a pigtail here. It's the DSA image. So ignore that. That's artifact. You'll see it here, and I'll show you. Oops, let me play this again. In the femoral here, you see that dissection there, right? So now the question is, what do you do? We had a catheter from the other side, so we would cross over here, and the way crossing over can be with any catheter. You can use a mammary and then use a coronary wire or a 035 angle glide wire. But you have to be careful, especially if there's a dissection, that wire doesn't go down and lift up that dissection flap any higher. So this was this particular catheter is called it was an OmniFlush, just a very easy catheter to use. It has multiple holes. You can inject, do an aortogram, but it also has this hook so you can cross over. So that clearly on this picture here, you can see the dissection and the disrupted lumen. So further down, there was really, I'm sorry, these supposed to play automatically. There's the SFA and everything's fine. It's really right in the common femoral. So what would people do here? How many people would wire and stent? How many people would send to surgery? I mean, there's a debate. So in the SFA across the femoral head. In a younger person, there's some debate about whether the safety of putting in a stent across the femoral head, because that's a point of a lot of stress. There's a lot of movement in that artery, and so you can't put a balloon expandable stent in the femoral because it will just get crushed and you'll create problems. But the question of a self-expanding stent, even that's sort of controversial. In a 70, 80, 90-year-old, it's probably not that big a deal. But in someone that's younger, it may create long-term issues, and the surgical repair is a very straightforward repair, so some people would argue maybe you should do that. This is an elderly patient, and so the lesion was crossed easily with an angle glide. This is a glide cath placed distally. So now you have a glide catheter, so we put a stiff wire or supracore, and this has come from the left groin now, up and over the aortic bifurcation. Exchange for a sheath. A balloon inflation was done, and this is the result. It really makes no difference. There's clearly a large dissection flap, and given that the risk of that creating obstruction to flow, decision was made to go ahead and put a stent there. This is a self-expanding nitinol stent, and the only things you can put are self-expanding stents in joints, in movable joints like this, because you don't want to put a balloon expandable.
These stents, which you can bend right angle also, the lumen doesn't come, like self-expanding nitinol stents.
Right. Yeah. These are. Yeah. This is the nitinol is good. The issue is the nitinol with a lot of motion. Nitinol in a lot of applications tends to fracture under a lot of stress and motion. So in a young person where there's they may be more active, the risk of fracture and further and restenosis is the main thing, because the likelihood this will be fine. There is a chance of restenosis, and especially if you have nitinol and stent fracture and things like that. But in 80-year-olds and 70-year-olds and patients with limited mobility, it's not going to cause much harm. So patient symptoms went away. I'm running a little bit short on time, so I just want to get through the last couple cases. So there's a 59-year-old gentleman, prior cabbage, had symptoms, class 3, class 4 angina. So operator decided to open a total occlusion of the right coronary artery. They wanted dual access. This is the left groin. And you see here the issue. I mean, the inguinal ligament probably runs from here to here, right? And this is the femoral head. The access is retroperitoneal. Where the needle entered is retroperitoneal. So there's no way to compress. This is where the artery dives deep. And And so it's a big problem. And there's a couple other shots here now of the same thing. You see clearly where it enters the vessel. It's incredibly high. So now the question is, what do you do? First of all, the first thing is it's an elective case. Would not give heparin or anticoagulate and go ahead with the case. Because then you just increase your risk of complications. For an elective case, don't go forward at this point. And this is, I don't think the pigtail's an issue, but it's not a compressible area. And so that was I think a 7 or 8 French sheath, because there was a CTO and they had failed attempt and they wanted new devices, so they were using a larger sheath for the ability to use other devices. So they were concerned about just pulling and holding, because it's not compressible and your risk of retroperitoneal hematoma is increased. So this is a technique that I use on a lot of my patients. I do a lot of aortic valve procedures and large sheaths, and for complications, is to cross over and balloon tamponade from the internal. So from the right groin, you cross over, you get a sheath and a wire down into the SFA on the left side. And basically you inflate a balloon, so the balloon is advanced to the site where the arteriotomy was done. The sheath is pulled, the balloon is inflated internally, and compression is held externally. And so that gives a period of time to get a hemostasis. Balloon's gently let down, and then further pressure is held. But the real advantage is you can see. So they kept the patient on the table 15 minutes and re-injected to make sure that they'd gotten adequate hemostasis. So that was done. It might not have been necessary, but the concern was that it was so high that they would not have been able to compress. I know I'm a little bit, my time's up here, but I'd like to just show, if it's okay, just the last case, because I think it is illustrative. This one's simple, but I'll show the next one, which I really want to get to. This is actually a case of mine. ST elevation MI, got access, did a groin shot, and you see here contrast extravasation. Is that clear right there? From right around the sheath. I probably entered this branch, and this one I can say for certain, because this one is my case. I probably entered the branch, and I don't know if the bleeding is because my needle injured the branch and created some laceration, or I'm bleeding around the sheath. It's a STEMI, and so I have to move forward. There's no way I can bring this patient back, and time is important, so I want to go forward. So the quick concern was, am I bleeding around the sheath? So what I decided to do, I went up to an 8 French sheath and upgraded the sheath size, and proceeded with the case. And with the sheath upsized, you see here, it tamponaded whatever bleeding there was. So the patient was fine. At the end of the case, the sheath was pulled after the anticoagulation wore off. I'm going to skip this here. Just want to show 2 real quick ones. Again, I'm sorry about running over here. This is femoral access, straightforward case. They tried to do a per close. It failed. They did a second per close. And the patient complained of numbness in the right lower extremity, and the extremity was cold. Doppler showed no pulse. And this is what the iliac, you got access on the left side. This is what the iliac angio shows. And what happened here is the per close got the back wall of the vessel, and basically it sutured the vessel closed. And this generally should go to surgery. This was a very sick elderly patient, because the issue is, if you balloon this, you can imagine you've sutured the back wall or the front wall, and the way that happens is just bad technique. Basically you end up pushing too hard as you're deploying, and the feet have caught both, and you've gone through and through. They elected to do this percutaneously for multiple reasons, because of the clinical situation of the patient. And so they were able to get a wire through. You see the wire here distally. They took a small balloon, a 2 millimeter balloon, inflated at 10 atmospheres, and this is the angiogram you see here. You see clearly this is where the suture was. There's some flow, but it's not great. Go forward here just in the interest of time. And they did larger balloon inflations, and this is what the flow looks like. You open up the vessel, you probably broke the suture there. And if you're going to do this, you got to be prepared to put a covered stent, because you could break the suture and lacerate the vessel. They broke the suture, but didn't lacerate the vessel, and there was a dissection. So they elected to put a stent, and that's the final result. Got away with it in this case, but in general, these type of scenarios should just be a simple surgical repair. You go to surgery, you take out the knot, and that will be the end of the situation. One last case here. This is the last one, I promise. This had a prior cath. This was the angiogram from that. We didn't find out until later, but they had done an angioseal. This vessel is probably not it's a reasonable vessel, but it was a small size, but they did an angioseal. She was discharged home. She started complaining of pain in the left lower extremity. She thought she had a clot. She went to the ER. Arterial Doppler really didn't show anything. Venous Doppler didn't show anything. And so they ended up putting, the patient was going for a cath. They took the look at the right, and they did an aortogram. See a lot of vascular disease, but you see a cutoff down here a little bit. So they went up and over and took a picture with crossing over, and you see this. And this is an angioseal, and that's the foot of the angioseal, which is basically flopping around in the vessel and is occlusive. Not occlusive, but it's obstructing flow. So there was a lot of discussion, and this patient, they did a surgical repair. It was a straightforward, quick repair. Basically took it out, put a small patch, and the patient did fine. You know, these type of vascular closure complications, you have to be careful about trying to treat endovascularly. You know, that angioseal is a increased risk of further embolic events. So that was just sort of a brief overview of cases, and I'm sorry I ran over time there. Apologize for that. Any questions or thoughts?
Yeah, if there are any questions, I think excellent presentation. Especially here, it is very important for us to see all these complications because most of us have turned to radials. And there are some patients which require complex intervention angioplasty, you have to go femoral. So you should know exactly where to puncture and how to do. I think it's an excellent presentation and good cases he has shown. Thank you very much.